Hi, everybody. This is Sharon Anderson, and I am president of Leiomyosarcoma Support and Direct Research Foundation. Today, we're really thrilled to have someone from AlēvCare from Arlington, Texas, to talk to us about uh, hospice and to answer your questions. So I'd like to welcome Michele Sobczak. Did I say your name right?
Yes,
Okay.
thank you.
And we're going to let her have the form. If you would keep muted until it's time for questions, or actually, do you want them to ask questions as you go?
Well, if it's okay, I'll go through the information that off the top of my head, and then, of course, questions after. And again, I'm sorry about my voice. It's been squeaky all day with allergies here in Texas, so I just apologize. But my name is Michele Sobczak. I have been with AlēvCare I'm in my 6th year. My background is social work, geriatric social work, and I got into caring for um, educating and caring for hospice patients about 20 years ago. And it is a passion and an important service that so many people are not aware of, the true benefits of hospice. Um, but I'll start out with, first of all, I'm sorry that you all are on this journey. I know it's got to be hard, but I think it's wonderful that you all have each other to support one another and give each other resources. And off the top, I wanted to make sure I don't forget the even if someone is not on Medicare, if you're just dealing with insurance or whatever your area is in the country, if you go to Medicare.gov, Care and Compare, I don't know if you're aware of this, but you can compare the different agencies, whether it's hospice, home health, nursing homes, anybody who is paid by Medicare, because they send surveys out, Medicare does, to families after we've cared for people. And they're given it's a rating, and we have 5 stars, and that's based on the families that we've cared for. So you want to do that because there
Well,
are some
resource. Yeah,
yes,
that's a wonderful resource. Thank you.
some of those, there are some 1 and 2 stars out there, and I would have look at the scores and see what they were rated overall. So that's just something I don't want to forget to tell you about. Um, so when the decision to, first of all, I know that it's a stressful thing to make a decision about hospice. And in the way we used to think about it, even me with my grandparents, you think it's the last days of life. And it's not that at all. What is decided is if the doctor says, or you can decide you don't want treatment anymore and you feel like it's not helping, the side effects are worse than the treatment itself, as far as the effect is going. Um, but when someone can be given the prognosis of 6 months, if the disease progresses at the rate it's going, at 6 months, if the doctor feels that could be the prognosis, that's when they would recommend hospice. Now, you don't have to wait for that. If you decide you're done, you don't want any more treatment, you can talk to the doctor about that option. Um, and that includes immunotherapy, chemo, radiation. None of that is covered under hospice. So when that decision to stop that is made, then hospice can be involved. So the doctor would have to write an order for an evaluation, and the family, of course, will meet with the whoever you decide to meet with whoever the hospice agency would be. And you ask your questions, and there are questions online that you can find to ask hospice agencies when you're interviewing them. Um, the criteria it varies. So if it's, let me back up a little bit. So if the doctor feels like you have more than 6 months, if that's a prognosis, then there's something called palliative care. And that's not us, but there are agencies that do palliative care, which means you can still get aggressive treatment, but then they also manage your symptoms. it's like a monthly visit type of a situation. With hospice, you get a care team. So you have an RN case manager who manages the care of the patient who's on hospice. And then for us, we make at least at least 2 visits a week. Sometimes families don't want 2 visits and they just want the one. But there's always a 24-hour number to call. So in an emergency, in the middle of the night, breakthrough pain, any symptom issues, there's someone to call if you're on hospice. There's a hospice aide that most of the time, 3 to 5 times a week is what families need. That they help with bathing and dressing and cleaning up the immediate area for the patient. They can shampoo hair, shave the gentleman, that type of thing, personal hygiene. There may be a point when someone can't make it to the shower and they can do bed baths. And then we have a social worker. She can help with all kinds of resources, but she's really a support to the family. And, she helps with anything from veterans papers, veteran services to a placard, handicap placard. We can get the medical director to sign that. So she can assist with that type of service. Family leave forms, our medical director, she can get the medical director to sign those. And then we have a chaplain who's there for spiritual support. They're not there typically, in most hospices, they're not there to represent a religion. They're just there for spiritual support for the family, for the patient and the family. Um, the process is the doctor writes the order, you meet with the hospice. There's paperwork it's called consent to treat. And that paperwork needs to be filled out before the nurse can admit the patient to hospice. And then the nurse would go out and visit about what the medications they have, what what their goals are of care. And also we can order medications we will pay for and order the medications and have them delivered to the home. Our medical director oversees the care. And so in the middle of the night, if somebody's having an issue with pain, that their pain meds aren't working, or they're nauseous or out of control, anxiety, whatever it might be, then we can manage those symptoms. So it's any symptoms that are causing discomfort, we address that with medications, with support, and then the nurses educate also along the way as to the disease process and what to watch for. Also, I did notice on one question that you had, yes, you can discharge from hospice if you decide you want to try a trial study that's out there, or you want to go back for treatment or a different route, then you can come off hospice. Typically, if it's Medicare, they don't love it when people come on and off too many times because they're thinking that, well, maybe it's not time for them to be on hospice. But if but I have had people who have come off to go back to immunotherapy and then maybe for a trial study. Um, so the medications, anything we can pay for under the hospice diagnosis, we do. The nurse has to look at that to see. There are some things like thyroid, statins, those types of things that hospice doesn't cover. You can still continue those medications, but just continue paying for them the way you've been paying for them. But the hospice will cover the medications as much as possible. Are you able to understand me through my squeaky voice?
Yes, we can. You're doing beautiful.
Okay. Also, equipment, if anyone needs oxygen, a hospital bed, a wheelchair, walker, bedside commode, a shower chair, um, anything like that, then we provide that. That's paid for also. So you don't have to worry about getting a bill for those things. That's covered. If someone has pressure sores or wounds that aren't healing, then they can get a low air pressure mattress, which helps with the comfort. Um, if anyone has Plurex or any kind of an ostomy of any kind, then we provide those supplies also, and incontinence supplies as well. So that would be any of the adult diapers or the briefs, uh, wipes, the gloves, the underpads that go on the bed. If that's all you would need, then people you don't you don't have to take all these things, but these are all the things that are available if you do want them. And then the barrier creams and that type of thing that go with the incontinent care. Can you think of some things now that I've just got a little bit of a rundown? Do you have any questions at the top of your head?
Is there any cost to the patients? Does Medicare always pay for this?
Yes, Medicare does. It's also to go over that. It's traditional Medicare. So if someone has an Advantage plan, the hospice benefit is covered under the traditional Medicare. It doesn't. We don't have to have approval. There's no copay or anything like that.
That's
It just
wonderful.
reverts back to Medicare, traditional Medicare. Now, if it's a younger patient that's not on Medicare, there are insurance agencies that work with hospice agencies. Our owner, he works with all agencies, and if they don't pay him, he doesn't send bills. He just, he works with them, and if they don't work with him, then that's just fine with him. Not everyone is like that though. So if since you're in other states, you would definitely want to do your research if you don't have Medicare, but traditional Medicare covers it.
Oh,
You never
great.
get it all. We've
And
paid into that all our working lives. Yeah, I'm sorry.
yes, we have.
Yeah.
That's a benefit. Marge asked, how soon can they set up? How long does it take?
For us, see, it's hard to say across the country, but for us, we have had an oncologist call us and we've had someone out there. I've gone out to do the paperwork within an hour and we've had a nurse out there. It doesn't always, it depends on the agency,
Right.
but
That
it
makes
can
sense.
happen quickly. And we do have to have the doctor's order before we can do anything.
And of course, the patient has to sign the consents.
Right, that's right. Or if they're not able to, then the medical power of attorney can do that.
Okay. And Nicole asks, who decides? Where is that chat? Who decides? Is it the patient or the doctor that you need hospice?
Both. It can be both. The doctor can recommend it. You don't have to, of course, that's your choice. But also, if you get to the point where treatment is too much, you are you just want quality of life, then you can make that decision and you can ask for that conversation with the doctor. Oncologists are not always ready to stop treatment. They want you to keep trying, but you have that choice. You've got the right.
Okay. And how do you involve families in this? I know it's usually a family,
Mhm.
a group process. So how are families involved?
Oftentimes, it is the family that reaches out to us, and we meet with the families. Some people have the whole family. They may have 8 siblings, and they all want to be there and have this discussion, and have questions answered. And then at the time of doing the paperwork, the patient lets us know who's allowed to have information about their medical care, and we keep that on record. So if anybody can call at any time on that list to get information, but the communication is really good with the nurse. They communicate with the patient's family if the patient wants that.
Okay. Okay. Anybody else have questions? Or if you have experiences to share?
That would be great.
I know you all have questions because you're here. So far what I got is it doesn't Medicare pays or
Mhm.
private insurance if you don't have Medicare. And there's usually no copay for patients.
No, not under traditional Medicare, no. Mm-mm.
Okay, so Carolyn Brown is coming in. Maybe she has something she would like to add. Carolyn, I'm putting you on the spot as soon as you get in here.
I have a question. Is that okay?
Yes, please,
Yes,
Casey.
Okay.
please.
So,
Please.
what services are often delivered in like a typical week? I know it's specific to a patient's situation, but
Mhm.
what often? I mean, like, are there services that are ones that you might not have already discussed, and um, are there things that, I understand and I've heard about, like you could provide services for people to have their wills made, etc. But are there other things like that that are, or like sometimes, hospice will have, someone come by and help someone make a will or help them contact someone to assist them with clergy, etc. Are there other things like that that are kind of, unusual services that we don't think about when we think about hospice?
Well, we have a volunteer coordinator, and I'm sorry I did not mention her earlier. And that is something pretty important to some people. They can be, sometimes we'll have, maybe it's a gentleman and the spouse needs to go out to the grocery store and run errands, but they don't want to leave them alone. Then arrangements can be made for our volunteer to come in. Now that is not on it's not 8 hours a day or anything like that. It would be a couple hours at a time. Um, and then, yes, our social workers are, so they're great with resources, and they're notaries, so they can help with. We do have what's called an out of hospital do not resuscitate form, and the social worker assists with that at the admission if that's what the family would like. And that is only, it strictly addresses cardiac arrest. So that would mean you wouldn't want the complete, CPR, and sometimes it can break ribs, and it's pretty aggressive. So if someone does not want that, then the social worker can assist with that, and she can notarize that. And then we send that to the medical director. He signs it and then sends it back, and we have the patient keep that in their home. We have a, child life specialist. Not everyone does have one, and she works with the patients and the patient's children or grandchildren, depending on the age of our patient. And it helps sometimes the parents of the children to help navigate the disease process and the changes, and the grief process as well. And she is also our bereavement coordinator, so she stays involved for a long time.
Oh, that's a
Um,
wonderful service too.
Mhm. There are some agencies, we don't have a massage therapist, but there are some agencies across the nation that do. Some do aromatherapy. That is kind of individualized though to the different agencies. But you did ask me something about a typical week. I would say could give you an example. Someone who may, and I do want to emphasize, if the option is to go ahead and initiate care earlier than later, it's so much less stressful. It gives you a support system, and you've got that set up when you might have a crisis, instead of waiting till it's a stressful time when you are rushing around and need that care. So we have some patients who just want the one nurse visit a week. That's it. They don't want anybody else in their house. They don't want anybody to call them or anything. We have other people who have a need to be seen every day by a nurse if they're having symptoms that are out of control. Some have a nurse aide every day, and some don't have any aide assistance. So it's very personalized and depending on the needs.
Thank you.
Yeah.
So Marge has something in the chat. She asks that she's been in palliative care since last summer, and she wants to know if palliative care and hospice work together. So or do they move from one to the other, or are they separate organizations?
Typically, they're separate. There are some organizations that have both palliative care. Excuse me, I'm going to drink something else so it won't squeak so much.
Well, we appreciate
I'm
you doing this with a
so
bad
sorry.
voice. So
Well, I'm not sick. It's just whatever craziness in the air. Um, yes, some agencies have palliative care and hospice care, but we don't. We're just strictly hospice care. They typically operate separately because with palliative care, I don't know what services are you receiving currently on
Marge, you
palliative.
want to unmute and talk?
Right now it's just once a month and nothing, she just checks on me. So we haven't done anything major. She hasn't prescribed anything for me, but yeah,
Oftentimes,
go ahead.
no, you go ahead.
No, I was just going to say once a month. She comes once a month and checks up on me to see how I'm doing. And like I said, I haven't really had much that she's had to do for me.
Well, and what I was going to say is sometimes in between those visits, if the pain is not managed or any of the symptoms that you're having are not managed, that may be a time to have a conversation about looking into hospice care because then they're available 24 hours a day. You know, when if you need something in the middle of the night, if you're having, and when I say symptoms, I mean that addresses pain, anxiety, agitation, um, shortness of breath, trouble sleeping, um, anything that causes discomfort.
Okay, thank you.
So Casey's asking in the chat, how do you serve patients with limited English or disabilities?
You definitely, depending on where you are, you definitely want to see if that is a concern, that the staff that they have with the agency has someone who's bilingual. If not, then we've had families that have been Vietnamese, and we have not had somebody on staff that spoke Vietnamese. So there's a language line that can be used. Agencies use those to help with that communication. And I'm not sure what types of disabilities, but I really don't know how to answer that one. We definitely can work with all issues. Any
Okay.
specific disabilities that you're referring to, maybe?
I was just thinking about maybe who had intellectual disabilities or who had,
Oh, yeah.
yeah, yeah, perhaps.
Yes, we have so many different types of diagnosis that we care for. So um, we do have people with dementia, with Down syndrome. We've had, all types of with different mental health disorders, perhaps. I don't know if that's what you're referring to, but yes, hospice care involves all of that.
That's great. I have a question. When you're on hospice, what treatments can you have? Can you have radiation if all of a sudden you want to do that, or surgery, or do you have to go off of hospice to get treatments?
Yes, because you'll want your if I'm just saying it, assuming it's Medicare, you'll want that treatment and that surgery and any of the bills incurred there, you want that covered by Medicare. Medicare either pays for the hospital and the treatment or hospice. So you would want to discharge off of hospice to pursue that.
So they
And
won't pay for this together. They won't pay at the same time for both.
right, right. Now, we have had patients in the past where the radiation was just for palliative care for just a few visits. So we paid for 3 or 4 visits just for the comfort. But typically, if you're doing aggressive, that's considered aggressive if it's long term or you're going in for surgery. But then you can always come back on hospice.
Okay, that sounds wonderful. So let's see. It says, Caroline, welcome, Caroline. Are there supports offered to family members after a person on hospice passes?
Yes, we have got a bereavement support program. And like I said, the child life specialist also. I'm sorry, I'm going to take another drink just because it's squeaky again. And so all hospice agencies have a bereavement program, and that way they stay involved and support the family. We don't have a limit, but typically it's 13 months is what is the standard, but we don't have any kind of limit. If people need us and they need that support, then we're going to provide that.
Oh, that's wonderful. So,
Mhm.
Caroline, I'm going to put you on the spot. Would you like to talk about your participation
Sure.
with AlēvCare? I would
Thank you
love to
so-
hear what a volunteer does.
Sounds great. I'm happy to do so. Can you guys hear me?
Yes.
Yes.
Okay, lovely. I've been volunteering with AlēvCare for I think 4 or 5 years now.
Mhm.
Ever since they hospiced my grandmother, and I really appreciated the work they had done over COVID. And I have really enjoyed it. In my role, I do a lot of everyone's role as a volunteer looks a little different. In my because I happen to be the age of a lot of my patients' grandchildren, I end up coming and doing whatever things they would want to do on like a short family visit sort of situation where I might take them and we might, if they have a coffee maker available, we might sit and have a cup of coffee, or we might go and watch a movie together and talk about it, or play games, or play bingo, or if they're at an assisted living center, I might bring them to an activity. So, for example, one of these assisted living centers near my house will do a Halloween party every year, and I will come and take one of my patients who is looking for a social outlet and might not necessarily have some, and take them out to go do trunk or treat in the parking lot. And so,
Trunk or treat, yeah.
it's people who are looking for companionship and friendship. I do definitely work with some people who are hospicing, but I also do a lot of working with people who are hospicing spouses, because
Mhm.
a lot of the times I work with couples where they've been married for 70 years, and this is the first time where they're starting to be away from each other in their entire lives. And so I get to provide companionship to the spouse who's already pre-grieving and sometimes isn't fully aware that their spouse is dying. They understand it, but they haven't accepted it. And so it allows like a bit of a transition where I can get them out into the community and engage with other people and encourage them to make their own friends and be with them as they do that, and just be supportive so that my patients, who sometimes I continue seeing long after hospice services have ended with them, but I can just continue being part of their community and encouraging them as I visit new people and helping them found relationships. And over the years, it's looked very different with a wide array of patients. I have had some people who were nonverbal, and for them, I might just sit and talk to them for a little bit, or read something, or just kind of coexist and smile at them and let them hug me or whatever they're interested in. And I've had some people who were fully active, wanting to go out and do things, and were telling me, "Come on, we're going for a walk today," or all sorts of other things. It's been really rewarding. I really enjoyed the experience.
And we're so
Well, thank
grateful
you,
for
Caroline.
you.
Yeah,
Thank you so
bless you
much.
for
We're
that.
so grateful. Yeah, makes
Yeah,
such a
that's
difference.
so I'm wondering if Casey and Brian, if you want to share something, what it was like being family members having hospice in your home.
Sure, Brian may want to add as well, but I think it was incredibly supportive. Here, I'll turn my video on. Let's see if I can. I would think it was incredibly supportive. And it was in the situation that we had, it was 24/7 from the get-go, which I know that that's not always the case, but it was a shorter term situation, and it was in our home. And so individuals rotated through, but what was really, and of course it was very sad, it was very difficult, but what was supportive about it especially is that we had continuity of care with individuals coming through who were the same individuals. And we knew the schedules, and they were there to support and assist, but also to take that on the side role, because they weren't trying to take over or anything like that. But they were there to support the needs of the family member, but also and then after the passing of the family member, they were also there to contact, the funeral home, and to contact the physician, and to do all of those things, and to remind us about the things that we needed to do next as well. But Brian,
That's really important.
One
That's a
of the
great
things that
support.
That was
Michele,
great information.
one of the things that Michele shared is that, like, the turnaround from the time of the decision to actually hospice starting can be very short. It's a very short period of time. And so I brought my mother home from the hospital at, like, let's say like at noon, and I think we had a nurse doing hospice intake by 6 o'clock that night. It was very quick. We did have a nurse 24/7 she only, when my mother came home from the hospital, she was only alive about 2 weeks or so. And so, but we had a 24-hour nurse there. There was, I think they did 12-hour shifts. There was two different ones. And it was absolutely phenomenal. I had not had any experience with hospice prior to that with my mother. And it was, it worked for us. It worked for our family. It worked for my mother. It was my mother's decision to do that. And so, it got us through all of the things that we couldn't think about or didn't even know to think about. And so it was actually wonderful.
And the
Wow.
Thank you
supplies were
so
there
much.
also, like the hospital bed and all the things we didn't think about were already delivered via hospice. They'd already arranged for all those things before she was brought home from the hospital.
Oh yeah, that's right. That everything showed up like before we got my mother home,
Mm.
because the decision had been made. But then, it was like I said, very quick turnaround. I was extremely impressed. And then when she did pass, um, we had somebody besides the nurse. There was another person that had to come to pronounce, I guess, as part of the pronouncing, and they were there. I mean, it was literally like 2 a.m. When my mother passed away, and they were there.
Yeah.
So great experience
Well, and I'm glad you
for a
brought that
terrible
up.
time.
It is, but you want that support, if you can get that. One thing, I'm glad you brought that up. We didn't mention crisis care. That's a 24-hour care. That's usually when someone has either out of control symptoms that need somebody there around the clock, or it's called caregiver stress. So crisis care can be brought in for that. It's not usually long term. It's just until that's managed or under control. We do have there are different levels of care. So there's the routine care, like I mentioned, when the nurse would come in on a regular basis just to check up, but it increases as needs increase. And we have what's called heightened care now, a heightened care program. So if somebody is suffering and having a hard time getting things under control, then our nurse is there is there daily around over the weekend as well. And then crisis care is if those symptoms are not managed at all, if, with the medications that have been prescribed. We also have what's called respite care, which is something all hospices offer. So if, let's just say a family has an emergency, everyone has to leave town. Nobody will be able to stay there with the patient in the home. Then we provide transportation to go to a facility that we've contracted with where they have around the clock care. And then our staff will go in there to provide the care in that situation. And that's called respite care. That's up to 5 days that Medicare covers. Will pay for that. Thank you for bringing up crisis care, Brian.
Yeah, I have a question. Not all hospice is in the home, right? There are some hospice facilities.
There are hospice facilities. There are some people who may be in the hospital and are too fragile and not able to get home. It would be a situation where they might not survive the transportation. And there's something called general inpatient. So there are inpatient units in hospitals too, where hospices have contracts there. And there are freestanding hospice houses. There are some in the Fort Worth area. We don't have one, but there are agencies that do, and all across the nation as well.
Okay, and that would be good for people who are more private and don't want people in the home, maybe. Or
They do have to qualify for that, for the inpatient. It would have to be a symptom out of control situation type of thing. So
okay,
it's very short term. It's just for usually less than 2 weeks.
that's for in the hospital, but what about the
Right.
facilities? Do they have a special criteria?
It's the same thing, yeah.
Same thing.
Yeah.
Okay. All right. See, I'm learning a lot.
But then the social worker can help if if an alternative living situation would be helpful, like if it's too much work for a spouse or any of the family. So they can help with finding assisted living, or they're called residential care homes that are real popular right now. They're smaller ratio of patients to the staff.
Hey, thank you. Any other questions? Chris.
Hi. Yeah. Hi, Sharon. So we're on the younger side, so we're not in the Medicare group. We
Right.
would be in the private insurance group, and we're young enough that I'm on medical leave and my husband is still working. It sounds to me like hospice would not really work for us. I mean, unless it was a very short-term deal, because he couldn't be off work for 6 months to care for me. Is that, am I
Oh,
understanding it correctly?
you wouldn't have to. We've had patients who have still, they may have been on, I'm sorry about my voice. Excuse me. We've had patients who've been on pain meds and the spouse drives them to work and the visits were made at their convenience. And that was about a weekly visit for them. They didn't need any extra assistance at that point. But it was good
I'm
to have.
thinking,
Oh, I'm sorry.
I was just going to say, I'm thinking more of like I would be home, but he would need to go to work, but I'm on hospice.
Hmm.
So, there's nobody there. No caregiver like there
Well,
24/7.
we have a lot of people who live alone on hospice.
And how do they
Usually,
manage that?
if are you needing assistance during the day?
I mean, not right now. I'm just looking
Right.
forward.
Right. There are, and I know financially it's a private pay situation, but there are agencies, personal care agencies that you pay for a certain amount of time for them to come to be with you. That's separate from hospice, though. Yeah.
Would hospice be able to provide services during the day, say, or, while the spouse was at work?
No, it would be those intermittent visits
Okay,
unless there's a crisis situation or if it's something that can be planned in advance where a volunteer could come in, but it would not be a continuous daily 8 hour a day
well, that's good
situation.
to know. Okay,
But
so
they're
you need a caregiver there.
not, I mean, only if they require it. We don't
I
require
see.
it. If that's something that they need, then yes, that would be something they could arrange. We don't require that.
Okay,
Usually
okay,
there's someone that can be contacted in an emergency.
I see. Does that answer your question, Chris?
Yeah, thank you.
Okay, and
And then
Chris, every hospice program might be a little different too.
mhm.
So
Where
I
do
don't
you
know.
live, Chris?
I'm in
Chris, where
Georgia,
do you? Oh,
Atlanta,
in Georgia.
Georgia.
Okay. Yeah. So that would be something. I don't know if you heard the first part of the conversation. Even if you're not on Medicare, go on Medicare.gov. Did you hear me say that? Okay. Just to rate the different agencies and then take it maybe from there, and if you have people that you can get referrals from, get information, then and then do some research on them too. But as far as I mean, as far as regular care all through the day, that would be a privately hired somebody that you would have to privately hire. Yeah.
Okay.
I'm
Yeah, thanks.
sorry.
Or maybe have another family member come in.
Hmm.
Yeah, or a friend. Any
Right.
other questions, folks? No? Well, that means, Michelle, you answered a lot of questions already. You are
And
very
I will,
thorough.
oh, well, I'm glad. And I will send you my cell phone number. And that way, if you find out there are questions that people have later, you can reach out to me.
Yeah, that always happens, right? You walk
Yeah.
away and then you have your questions. So I appreciate that. And I appreciate your time and everything you do. I want to
Oh,
thank
absolutely.
Casey and Brian and Caroline for coming on and sharing your experiences too. I think that's, important to have that perspective. So,
That was helpful because it did trigger some things for me to mention, like the respite care and the crisis care. That's very important.
okay. Well, thank you all for coming. And this is a conversation to be continued.
Yes. Thank
All
you
right.
so
Take
much. It
care.
was an honor to speak with you all. Thank you.
Thank you so much, Michelle. Bye bye,
Thank you.
everybody.
Thank
Bye-bye.
you.